ओके डॉक्टर अपूर्वा, आप एक बार अपना ठीक है
शेयर कर लूं?
नहीं अभी
Doctors, we are live now. You can start the session.
Okay. Good evening, everyone. On behalf of Eye Surgeon Society, Karnal, I welcome you all for today's webinar on choroidal vascular diseases. It's my privilege to have a very esteemed panel of speakers and panelists. I and Dr. Adviti Arora, on behalf of Eye Surgeon Society, again welcome. Our panelists are Dr. Chekitan from Rohtak, Dr. Mohit from Ambala, Dr. Manish Dhupar from Hisar, and Dr. Raghav from Yamunanagar. I welcome you all. First of all, I'll request Dr. Adviti to introduce our first speaker, Dr. Apurva Grover. Over to you, Dr. Adviti, please. Dr. Adviti, you are muted.
Yeah, it's okay now. Am I audible?
Yes, clearly.
Okay. Very good evening to all of you. A warm welcome from Karnal Ophthalmic Society. Dr. Apurva Grover is currently Director and Consultant Vitreoretina Services at Vision Eye Centers in Delhi. He has gained extensive experience in his field as a clinician and surgeon, having worked at high-volume vitreoretina setups as a former fellow at Arvind Eye Hospital, Madurai, and as a past consultant at Sadhguru Netra Chikitsalaya, Chitrakoot. He has been a part of several instruction courses at the annual conference of All India Ophthalmic Society, a speaker and faculty at various international and national meetings, including World Congress of Ocular Trauma, Asia Pacific Academy of Ophthalmology, EU Retina, and Vitreoretinal Society of India. So over to you, sir.
Thank you, ma'am, for the kind introduction. I'll be sharing my screen. My slides, are they visible?
No, sir, not yet.
Not yet.
Is it seen yet? No.
No.
Okay, let me try again.
Yes, sir. Now it is visible.
Yeah.
Yes.
Okay. Yeah, is it seen now?
Yes.
Yeah, thank you.
Yes.
Thank you, everyone. Thanks to the Karnal Ophthalmic Society for the opportunity. And thanks to Team Novartis for having me here. I'll be speaking on unmet needs in the management of neovascular AMD. This is the disclaimer from Novartis. I'll be speaking under the following broad headings. Firstly, the need for effective therapies in neovascular AMD, the extent of the problem, continuing decline in vision in real-world clinical practice. We'll talk about the burden it presents to the healthcare system, burden it presents to the patient, and a summary of the above. We'll start with the need for effective therapies in neovascular AMD. We'll start with the overview. AMD, as we know, is a leading cause of severe and irreversible.
Apurva, can you go into the slideshow, please? I mean, it's still showing in the slide. It's not on the slideshow.
Is it? Okay. Now?
Not yet, sir. Not yet.
Okay.
Just do a stop share and share the slideshow again.
Okay, I'll do that. Just a minute. Now, has it gone to the full screen now? Not yet.
So yellow, you just move it next to that 52%, no, Apur? Just go and click on that.
Just a minute. Now is it full screen?
Yes. Now
Yes, sir. Yes, sir. Now it is.
Okay. Yeah. So I'll continue with what I was saying. Yeah, we'll start. Yeah, is it full screen? I'll start now.
Yes, sir. Yes, sir.
Yeah,
Yes.
Okay, so we'll start with the overview of AMD. And age-related macular degeneration, as we know, is a leading cause of severe and irreversible vision loss worldwide. It's the #1 cause of blindness in developed countries now, and affects about 10 to 13% of adults aged over 65 years. As a consequence of aging population, rising life expectancies, its prevalence is constantly increasing. There were an estimated 196 million cases by about 2020, and this number is expected to rise further in the coming years. Although dry AMD form the majority of cases of age-related macular degeneration, however, the majority of vision loss, about 90%, occurs because of neovascular AMD, which is only about 10 to 15% of cases. Yeah, so this is the data from developed countries. AMD, neovascular AMD, is the leading cause of blindness in the developed countries. As you can see from the pie chart, about half the incidences of total blindness, severe blindness in developed countries occur because of neovascular AMD, which is almost equivalent to all other causes combined. Hence, and this is likely to be the scenario even in developing countries in the future, like India. Research over the years has focused on effective therapies for neovascular AMD, where in the pre-1980s there was no treatment. In 1980s, we started with thermal laser, which still progressed to scarring and recurrent neovascularization. In the early 2000s, we started with PDT, which, although it slowed the progression of vision loss, however, in the majority of patients, there was still no visual improvement, and they still slowly progressed towards vision loss. However, after 2005 onwards, as we all know, anti-VEGF therapies have changed the paradigm completely. Now you can not only stop the progression of disease with these agents, but also you can expect visual and anatomical outcome improvement. It has dramatically reduced the incidence of blindness due to neovascular AMD. As you can see from this population-based study in Denmark, the incidence of blindness after the introduction of therapy has nearly halved in the population. Anti-VEGF agents now, as we know, are the gold standard for neovascular AMD, which has dramatically reduced the incidence of blindness and severe vision loss. However, in the real world setting, we still see that we are not able to match the outcomes that we see in clinical trials. And hence, there's an unmet medical need for newer treatment options that can reduce the treatment burden and also have a longer duration of efficacy. Hence, there is a need to build on successes in neovascular AMD care and continually innovate to prevent blindness caused by the disease. We'll talk about the extent of the problem now. The global burden of neovascular AMD is, and the cases are expected to rise, and this rise the maximum in Asian countries where the population is rising and also at the same time life expectancy is rising. So this is likely to make the burden of neovascular AMD even greater in the coming future, especially in Asian countries like India. This increase in prevalence is set up against costs that are already high. As you can see from the data in developed countries, the patients with neovascular AMD have substantially more health resource utilization costs as compared to controls, and it almost forms about 0.5 to 0.6% of total health related expenditure in these countries, which is massive for a single disease. So to summarize, increasing prevalence coupled with high costs, high resource utilization for the healthcare systems will be extremely difficult to manage as the cases rise in the future. We'll talk about continuing decline in vision in real world practice. As we discussed before, in real world, we are often unable to match the outcomes that we see in clinical trials. And this is often associated with lower under treatment and infrequent treatment as compared to the trials. Because of high treatment burden, we are unable to practice the regimens that we see in clinical studies, and often we practice other regimens like treat and extend, PRN. And as a result, we often see that initial visual acuity gains that we see with initiation of therapy, we are unable to maintain them following once we start the treatment over the next few years. And this happens because of under treatment often. And we can see that lower injections are associated with poor visual acuity gains over time. So to summarize, in real world clinical situations, we see that vision continues to decline in neovascular AMD patients. And this is linked to the low frequency of treatment and monitoring, often missed monitoring visits and missed treatment. We'll talk about the high burden it presents to the healthcare system. As we discussed before, the burden of neovascular AMD to healthcare systems is substantial because of high drug costs, need for frequent treatment and monitoring, and also because of the increasing prevalence of the disease. And this has led physicians to explore different regimens for anti-VEGF therapy. Physicians have adopted regimens like treat and extend, PRN, to increase individualization and to reduce the burden on healthcare sources. However, this often results in delayed detection of recurrences, and this delayed detection may result in slow loss of vision over time due to scarring. So when retina specialists were asked about why they prefer discontinuous regimen, they often said that patients as well as physicians, in spite of the fact that it may result in some vision loss, they said that they prefer discontinuous anti-VEGF treatment because in the real world scenario, they were unable to constantly administer injections as per clinical trials. So once we follow the patient over treat and extend, we see that the risk of CNV activation, reactivation increases over time, especially when we increase the duration of injections, the interval between injections, to more than 8 to 12 weeks. And this may result in reactivation of disease and some scarring, and this vision loss may not be recovered over time with subsequent injections. We'll talk about the unmet needs from the physician's perspective. When this was a study conducted by ASRS, and physicians were quizzed about the greatest unmet need regarding neovascular AMD treatment, and most of them said that reducing the treatment burden and having a long-acting sustained delivery was the most important greatest unmet need regarding neovascular AMD treatment. So to summarize, to deal with high treatment burden, physicians have adopted different regimens which can result in reactivation of the disease, and this can take longer to treat, and it may cause some vision loss due to scarring, which may be irreversible over time. We talk about the high burden to the patient. The need for frequent treatment and monitoring places a heavy burden on the patients, and over time it is seen that the patients tend to discontinue therapy, citing a variety of factors such as transportation issue, high cost burden, dissatisfaction with the benefits of treatment, and patients' lives are preoccupied by frequent visits. As this study demonstrates in the French journal, published in the French Journal of Ophthalmology, after a median of about 3.7 years, about 50% of patients tended to drop out from the therapy, citing various reasons as we already described. So to summarize, due to frequent injections, patients often undergo treatment fatigue over time and often discontinue treatment. So I'll summarize the above. So increasing prevalence coupled with high resource utilization is extremely difficult for healthcare systems to manage, and this is likely to worsen further as prevalence increases. In real world scenario, we often see that the vision continues to decline in neovascular AMD patient, and this is often linked to under treatment and infrequent monitoring. Patients identify reducing the treatment and monitoring burden on the patients and increasing the duration of efficacy of the treatments as key unmet need in neovascular AMD. And as patients undergo treatment fatigue, often they tend to discontinue treatment over time. And hence, this explains the need for long-acting drug delivery systems that can reduce the treatment and monitoring burden on the patients. at the same time achieve the good visual outcomes that we see in clinical trials. So yeah, this was my initial experience with the first patient I treated was a patient who had been lost to
I
follow-up.
summarize, sir, because
Yeah. This is just my last slide.
Okay.
Yeah, so this was a patient who had been lost to follow-up, was unable to come for frequent follow-ups for a long time and was lost to follow-up during COVID. Was traveling from outer station, so I could not follow up monthly, and I decided to go for Roluzumab. This was the first patient I injected. This was the pre-treatment OCT, and as you can see, after just one injection, 1 month, the fluid is completely resolved. However, the patient again missed follow-up for some time, and after presented after about 4 months with recurrence of the fluid, and I've re-injected this patient. Yeah. So yeah, this is the Paginax summary, and thank you for patient listening.
Thank you, Dr. Purva,
Yeah.
for your enlightening talk and opening the session. Sir, we'll whatever questions I request the audience to keep sending them, and we'll take them up in between the sessions. Next, I'll invite Dr. Chaitra Jaydev, a name which needs no introduction. She's a senior faculty at Narayana Nitralaya, Bangalore, and she's also the joint secretary of AIOS and VRSI. She is the scientific committee chairman of the Karnataka Ophthalmic Society. And ma'am, I welcome you to the webinar, and I request you to enlighten us further, ma'am. Thank you so much.
Thank you, Sumit, for that kind introduction and also for this opportunity. As Apurva has already told us, I think our biggest challenge has been managing patients in the sense that we want to increase the treatment interval, thereby reducing the burden on them. I think that was one of the primary causes that patients tend to fall out of treatment. Of course, the introduction to Brolucizumab has already been given. We have a decent amount of experience now for the past year. So I'm going to be highlighting a couple of cases on this. Am I audible? There's a little bit of background noise. So I hope I'm audible.
No, yes, ma'am, you're audible.
No?
You're audible, and
okay,
slides are also visible.
Great. So this is my first case. This is a 70-year-old female, decreased vision in the right month. Had already received bevacizumab for the right eye several times before. It was taken really 2 years back, and the eye unfortunately was already lost to a scarred CNVM. So this you see is a picture at presentation. The left eye is badly scarred, and the right eye is just presenting to us with the disease. And despite equipment, you can see some amount of scarring. So this is how the patient presented to 2020. She came to us with vision, and we told her we'd like to try. She was more than willing because her quality of vision was also pretty poor. So this is immediately post the injection, and just with at 1 week, you don't expect such a huge cyst to regress so fast. So I think that's one of the main, factors. I think Brolucizumab helps us in terms of addressing this fluid, and not only in the intraretinal compartment, a lot of fluid in the sub-R space tends to resolve. This 4-week injection, and with this 1 week, one injection, we've been able to maintain this patient for up to 3 months post injection. So she's doing pretty well. So this is another patient, 58-year-old female with a solid PED and SRF with 3 loading dose. Also, she was not doing very well. Here you see her vision has been pretty good. Though, of course, the quality of vision was not very great. This is in the loading dose. This is another drug we used in Jan 2021, Feb and March. You can see some resolution of the subretinal fluid, but the PED more or less has remained the same. So this is since there was persisting SRF after 3 doses of the anti-VEGF, we decided to switch in April 2021, where we gave the first injection of Brolucizumab. And you can see within 1 month, the subretinal fluid has also come down well, the sub-RP fluid also. This is what I was talking about in the sense this drug is doing wonders in fluid in all the 3 compartments. So from April to May, she stabilized, and again from May to June, we decided to go ahead with another injection to continue stability of the disease. And she continued to do this. On the last step, if you can see, the disease is very, very steep. But the 58-year-old gentleman, this is an interesting case. One eye right was already lost to the scarred CN glaucoma. Left eye had received multiple injections of bevacizumab elsewhere. When he presented, we wanted to see what is going on actually in this particular patient. We did an FFA and ICG. We found both polyps and a BVN. And you can see here, most importantly, you can see a very, very large PED in the patient. This was in May 2020 and June 2020 with the bevacizumab. Not a great response. Intraretinal fluid is definitely coming down. This was in August 2020 when we switched to another anti-VEGF. And again in September, it was waxing and waning. And this was in 27 of this year. You can still see a huge PED. But what happened when the patient came to us a month later and follow-up was a massive increase in PED and a lot of subretinal fluid. So we, at this point of time, decided that we'll go ahead with brolucizumab, and the first injection was given on 27th of February, and we kept a close watch on this patient because we were, as I said, he was a one-eyed, and when we called this patient on 6th March, see the difference. There's a reduction of PED height and also the retinal fluid has resolved. So we continue to follow this patient. There's a 1 month follow-up post-injection, 20th March. You can see further decrease in the PED. Second injection, third injection followed, and the fourth was given in June. And you can see a 3 decrease in the PED height. And this was on last follow-up, very good resolution of the disease. Fourth case, a 69-year-old lady with mild decrease in vision in the left eye, 6/9 vision. You can see subretinal fluid and you can see a PED there as well. This was in 2019 December. An anti-VEGF was given in Jan and Feb. The disease kind of stabilized, but when she was lost to follow-up again because of COVID, she came back in end of December and it came further, increase in the subretinal fluid. Anti-VEGF again was given here in Jan and Feb, and then the fluid started coming down, going up. 3 months later, again, she presented with increased SRF. This is when we thought to give her the advantage of using a new drug. This was in July 19th when we gave the injection. By July 30th, you see in follow-up in 10 days, the fluid is almost, halved in height. And by September, at 6 weeks, the disease had stabilized very well. This was a treatment-naive patient, 75-year-old male, 6/12 vision, decreased vision around 15 days. Of course, there's an ERM, but you can see a PED and subretinal fluid as well. This is 4 weeks post the first injection. This was a treatment-naive patient, like I mentioned, and this is post the second injection. The patient is doing well. This is a 71-year-old male with decreased vision in both eyes, 6/30 in the right eye, left eye 6/9. So this was in Feb 2021. Patient had already had a RIP, as you can see. We gave the injection for 2021, but again, lot to follow up with COVID. Patient came to us next in August 2021. Again, this time the second dose of brolucizumab was given, and by September, the disease started getting better. And by October, he had more or less stabilized. This is a 68-year-old male, decreased vision in the right eye. Patient was 6/30. You can see how bad the disease is. This was in Jan 2020 and Feb 2020. I had some old pictures of this same patient, had been receiving, even IV care at that time. Then the patient presented to us this year with this much of exudation in September 2021. You can see the large cystoid spaces. I was wondering whether we can give him a trial of brolucizumab, and he responded extremely well. This is in October 2021, and this was in September. So good resolution there, still persisting with treatment. This is a rather long case, 65-year-old patient, presented to me way back in 2019 April with the left eye. You can see she presented with a large PED, already she had a RIP at this point of time. And the right eye had drusen and was stable, vision was good. So I started treating her with anti-VEGF at that time. Again, she responded very well, with another anti-VEGF at that time, and she was stable. And by August 2019, I decided to hold treatment because she was stable. She came back again in March 2020, for a routine follow-up, not with any major complaints. Left eye had explained to her that she may not be able to get better than this because of the RIP. Then she was lost to follow-up again, COVID. She came back, unfortunately, with the right eye involved, and again, right eye, she had a RIP. The left eye, was scarring, but had some amount of recurrence. I advised her injection. She underwent it, but not, the response that we would expect. And she was also not very, very happy. November 2020, again, we gave her the injection in the right eye. In Jan, we suggested a change of injection. She was not very keen. But since she did not respond too well by March 2021, she was ready to go ahead with brolucizumab, and that's when we gave her the injection in both eyes. The vision was 618 and 624, and you can see extremely good resolution. She was very happy with this one injection. So in June, we held the injection. We didn't bother to her because she was doing well. And then on and off, we've been treating her, and she's very quality of vision. And more importantly, we're able to space out the injections with her. So this is a patient with bilateral rip, other eye rip 18 months after the first eye. But eventually, she didn't have very, very great with both the sub-RP and the subretinal hyperreflective material. But eventual remodeling and scarring is expected in these patients. This is my case, and what I want to highlight is despite recurrence of activity, we are able to bring back, the patient to baseline every time we give the injection. Most importantly, we are able to space it out. This is a 78-year-old male, decrease in the right eye, CMVM. This is how it presents it to us. You can see retinal fluid. This is the first injection. Post first injection, you can see good resolution of the fluid, and this is again after 4 weeks. The patient would recur exactly at 8 weeks, and then would the second dose or the next dose again. So this is after the second dose. In 1 month, the patient starts solving. 2 months post, some amount of fluid is coming. So we are
We lost you in between, Chaitra.
I think so, ma'am.
So I think I was at my last case, Vinod.
Yeah.
Yeah, so I think issue with my network, but I think that more or less covered everything. So basically, what I wanted to show with all the cases was that I was able to, bring them to some amount of stability with brolucizumab, and most of the fluid would regress, except in the last case where unfortunately every 8 weeks the patient seems to be coming back with fluid.
Okay. Ma'am, I just want to ask you one question that in cases that most of your
Yes,
cases were the ones which had not responded to other anti-VEGFs like ranibizumab. So how do you choose between brolucizumab and Eylea? How do you make a choice?
Okay, so as of now, Sumit, we are giving the patients both of them the option. We're giving both drugs the option. And a lot of these patients also come with their insurance scheme. So it's not necessary that, whatever injection we offer them, they will take. Now, if you're coming specifically between Eylea and brolucizumab, well, it actually depends on the amount of fluid they have in each of the treatment and the disease. Now, with PCV, initially we didn't have any other option. So, Eylea used to be the first preference, but now we're I showed you some of the cases that I had given brolucizumab and PCV cases. These are patients who had somehow stopped responding to Eylea as well. And maybe it is the tachyphylaxis, or maybe it's the molecule itself, which is the brolucizumab, that it has definitely made a difference, and it has made an improvement in these patients. And in fact, all the other anti-VEGFs, I think the sub-RP fluid is the one that's responding fantastically with brolucizumab.
Okay, so ma'am, you would say that for those cases who have a sub-RP fluid or PCV, it works better than Eylea?
Not really. I'm not saying it works better than Eylea, but it does give some form of an edge when there is only sub-RP fluid. But when you're looking at PCV component itself, I think even Eylea has done wonderfully well. Okay. I mean, I have no complaints, but some I have at least 2 or 3 patients who somehow stopped responding after several, and now with brolucizumab, they've again started responding. Okay. So I think probably a change in the molecule has helped them.
Ma'am, have you encountered any intraocular inflammations with brolucizumab?
No, not really. Not in our institute. None of the cases that we've had so far, none of them had any intraocular inflammation or vasculitis or occlusion. I think overall in the country also they've seen at least about say 10, 12 IOIs and 1 proven vasculitis. But not in our institute. We have not seen any.
Ma'am, if there is a national data and it actually shows that the incidence of inflammation is not high, then do you think that it can be accepted as the primary line of therapy as compared instead of ranibizumab? Vinod sir and Chaitra ma'am, please on comments on these.
Yeah, I think so. Because luckily for us in our country, we have not seen as much inflammation as in the West, simply because I think we don't have as many usage. I think as our usages go up, we might get to know more. But I think close to 8,000 vials have been used so far, and the incidence has been about 10 IR, like I said. So right now, we're already offering it as a first line to our patients, but we're very careful when we choose our patients. No pre-existing or intraocular inflammation, and we also tell them to come back to us the minute they start floaters. Or any sort of discomfort, it's expected to occur. They say within 4 to 8 weeks duration is when they've seen the highest incidence. Vinod, your thoughts?
I think I'm not that prolific a user of brolucizumab till now, but whatever I have used a little bit, seems safe. The problem is not the effectivity. I think most of us know that it works very well. Why we are hesitant to use it is because of so much has been talked about the side effects it has had on the eyes, which uh, where it has been used. So I guess as we use more and more, we'll get to know more about the drug, its safety profile, and of course the preliminary whatever we have seen, it works very well. As a matter of record, one patient I had used in diabetic macular edema, which did not respond to anything. Previously, it did not respond to any of the anti-VEGFs, not even steroids. So I gave it a chance of using brolucizumab, and it did not respond to brolucizumab also. So uh, it's not that something which will work always, but as of now, we have to be careful. I have one question for Chatra, if you are there.
I'm here. I've just put on my video because I thought the bandwidth, the network would be better. That's why my video is off. I'm very much here, Vinod. Please tell me.
Oh, okay. So I saw that you've been using in treatment naive eyes also. So what is your follow-up protocol in such patients? Do you follow up them monthly, or how do you go about it?
So, Vinod, it depends. If I'm doing the loading dose, definitely monthly. I'm still doing loading dose for AMD patients, even with brolucizumab. And so, since I'm following them up monthly, I already know whether they're going to be prone to an inflammation or not. And I've already warned the patient that if you have any of these symptoms, to come back immediately. So that is one concern that's taken care of. What we did initially, if you notice, why I have 1 week follow-up of those patients is that because we were a little skeptical. So, initially when we started using the drug in Jan, Feb, we actually called patients within a week to see, but they don't present so early with inflammation. Most of the reports say they present anywhere between 4 to 8 weeks after any injection, not just the first injection. They've seen it even after the second and third sometimes. So it's just to be on the cautious side. I think we need to tell the patients what symptoms to look out for and come back if they feel anything. So now my follow-up has been so far, all has been for 4 weeks only.
And you give 3 loading doses?
Yes, for AMD.
Okay.
I have one question for Chaitra. Chaitra,
yes,
hi, Dr. Sekidan here. I just wanted to know the first, as first line therapy, how do you decide about brolucizumab as first line therapy? Because we have safer anti-VEGFs available like ranibizumab and Eylea. So my dilemma is always that because we have not experienced it, but we have read a lot about it, about the intraocular inflammation. So what makes you think that it should be first line? In which cases specifically?
So I was just mentioning before. So first line, I'm offering it for AMD patients if they can afford it, Chikitan. Or if, as of now, still I don't think they're covered under insurance for Paginac. But we have used it for a significant number of patients with AMD, and almost all of them are doing pretty well. Specifically with the large sub-RP fluid and subretinal fluid, also these patients are doing well. So if I see some sort of a pattern like that, and the patient understands about the drug, we are explaining to them and they're accepting of it, we are going ahead with it even at first line.
Recently, ma'am, I injected a patient who was covered by insurance for Paginax. So I think probably
nice.
they have started covering it now.
Yes, yes. I'm not aware, Apur. Maybe some of the agencies it differs from company to company, but
Right.
we probably have now. But initially, I think we didn't have. Probably now they have coverage as well.
Yeah. Also, in your experience, does it scare patients if you tell them about the possible risk of inflammation? Because I've often
Not
seen.
really, Apur. We've actually made a consent in which we have also given some references for them to read. Sometimes they're so desperate for better vision that
Right.
they sometimes oversee it. So we've made it very clear. We've given them statistics. We explain to them, the cons of it. The pros, of course, they understand. But as far as the cons go, we also tell them to be careful and to come back if there's something. Luckily, touch wood, we've not had any patients so far.
Yeah. Same here.
Dr. Mohit.
Hi everyone. Yeah. Hello everybody. Yeah, I just said Dr. Sumit raised a very important question. I think so. Initially we all were very skeptical about using this molecule, and we are using it more and more, we are getting more confidence actually. And the data in Indian population, there is hardly any inflammation. So recently I have also started using in few of my treatment naive patients, and it has done really good. We all know that in PCV it is really doing even better than Eylea. It is my experience as well. That as Dr. Chaitra said that subretinal fluid, sub RP fluid, it does the wonders in that situation. I think so. There is no harm in using this molecule, especially in our population in treatment naive patient also, because definitely the results everywhere, wherever we are all seeing each other's experience, we all are reporting very good experience, and none has seen any inflammation. And in my experience also, in good number of patients, I haven't seen any inflammation, and results have been really very good. Yeah.
Great. Sir, next, I'll request Dr. Adviti to introduce Dr. Vinod, our next speaker. Adviti, ma'am, please.
Thank you, everybody. I'm going to be there, but my video will be off. That's all.
Okay, sure.
Thank you.
Dr. Vinod Agarwal sir is one person who needs no introduction. He is a well-known personality in vitreoretina. He is additional professor at RP Center, AIMS, and he has done his retina fellowship from Wrexham Miller Hospital, Wales, and Gunma University Hospital, Mebashi, Japan. And he has over 200 PubMed index publications and many books and several book chapters. He is also the editor of Delhi Journal of Ophthalmology. We welcome you, sir. Over to you.
Thank you so much for the kind invitation. I'll share my screen. I hope my screen is visible.
Yes, sir, it's visible.
And am I audible?
Sure. Please start.
So I'll be talking about pachychoroid spectrum. Now, this is something I think most of you would have heard over and over again in past 2-3 years. And some of us have even got bored of it. But why I wanted to speak is, once we talk about choroidal vascular diseases, I think this is the most significant change which we have witnessed in past decade or so. So let's see what is a pachychoroid. Now, pachychoroid literally means thick choroid. It is a relatively newly recognized entity. And if you see, the first publication came somewhere in 12 or 13. And over the years, we have been having increasing number of publication in this particular subject. Now, what is pachychoroid? It is nothing but byproduct of newer technology. I think most of you would recognize this is how we saw our OCTs about a decade back. They were colored, and this is what we saw. And over a few years period, we shifted on to the black and white images as we realized that the contrast is better visible on black and white images. And as we shifted to black and white, Spade, who has discovered so many things in the field of retina, described the use of enhanced depth imaging, where we could see the whole depth of the choroid. And there came the concept of pachychoroid, that is thick choroid. Now, why one should have pachychoroid? So this is one of such examples. If you have a look at this particular patient, elderly male, if you see, fundus is by and large normal. The visual acuity is 6/6. But if you see, there are some pigmentary changes in the infratemporal retina, which are visible on autofluorescent imaging also. Now, have a look at the OCT. It is by and large normal. And if you don't have the concept of Pachychoroid, it could be diagnosed as anything, which could vary from pattern dystrophy to early AMD to RP, epithelitis, or PIC. But once we have the concept of pachychoroid, we have a look at the deeper layers in the choroid. We know that this patient has a deeper choroid, a thicker choroid, and we could be dealing with something known as pachychoroid pigment epitheliopathy. So basically, pachychoroid is nothing but it incorporates OCT to a larger level in our usage of multimodal imaging. It also helps us in understanding the choroidal pathophysiology in the setting of central serous chorioretinopathy and its allied broader phenotype which can occur. Now, what are the various features of pachychoroid disease? Now, before I tell you about the pachychoroid, one of the main limitation of the pachychoroid diseases till date is that there is no strict definition of the pachychoroid. Now, several people have tried limiting what is the thicker choroid, but there is no, again, universally accepted definition of a thick choroid. But yes, pachychoroid does entail having a thicker choroid. Now, typically these patients have reduced fundus tessellations. You cannot or you are not lesser able to appreciate the deeper choroidal vessels. The choroids tends to be thicker, which can be focal in a particular area, or it may be diffusely thickened. Now, what is very characteristic in these subset of patient is that the outer and the medium choroidal vessels are dilated and they impinge on the inner layer, that is choriocapillaris, and most of these eyes would have attenuated choriocapillaris and a thicker, larger and medium choroidal vessels. And these larger choroidal vessels which impinge on the choriocapillaris are typically seen in the area of retinal pathology, and they are known as pachyvessels. Now, just to give you a perspective, this is how age-matched control would have his choroid. This is a normal choroid. And if you look at the pachychoroid, you can make out how the larger outer vessels of the choroid are dilated and they are impinging on the choriocapillaris, and choriocapillaris is virtually attenuated. Now, when the pachychoroid spectrum was initially described, it had 4 entities in it. So we'll talk about these 4 entities and then I'll talk about the newer entities. Now, this was the first entity which was described, that is pachychoroid pigment epitheliopathy, which is the first or the component of the pachychoroid spectrum. Now, have a look at this particular patient, a 70-year elderly male, visual acuity of 6.6. On color fundus photograph, you can't see much, but if you see on autofluorescence imaging, there are some pigmentary changes in the superior macula, which are seen as window defects on fluorescein angiography. But once you go on to develop do the ICG angiography, you can see that this patient has dilated choroidal vessels only in the superior macula. And look at the OCT scan, which is running in this particular direction. The left one is macula, over here is the inferior macula. So if you see in the area of the affected retina, you have larger choroidal vessels which are impinging on the choriocapillaris, and there are some pigmentary changes which are visible on OCT as well. So this is what is pigment epitheliopathy. It has been considered to be form fruste of central serous chorioretinopathy. This can be focal, that is occurring in one particular area, or can be multifocal. And most of these patients should have no history of subretinal fluid or evidence of past or present subretinal fluid. So second component we are all aware of, it's very common in our day-to-day practice, central serous chorioretinopathy. You can see a middle-aged male with visual acuity of 6/12, evidence of chronic fluid in form of hyperautofluorescence and some hypoautofluorescence on AF. FA shows pinpoint leak, and if you see on on-fast OCT imaging, you can see larger choroidal vessels which are there in the macular area, more so in the area of retinal pathology. So we all know that CSC can be there in acute and chronic forms, and these pachychoroid changes are more visible in patients with chronic CSC changes and with complications. And this is the OCT scan of the patient, very typical subretinal fluid, a PED, and if you see, the larger choroidal vessels have virtually replaced whole of the choroid. They are there focally in the area of beneath the retinal pathology, and choriocapillaris is virtually vanished. The third component is PCV or polypoidal choroidal vasculopathy. Again, you see a typical patient, elderly gentleman with visual acuity of 6/18. You can see a hemorrhagic PD over here, large area of exudates involving the macula. AF in this patient does not tell you much, but on FFA, you can see ill-defined leakage in the form of occult CNVM, probably some polyps here, which can be confirmed on ICG imaging. Now, if you go on to OCT, again, you can see that this choroid is absolutely normal, but over here in the area of beneath the area of retinal pathology, you can see large choroidal vessels again impinging on the inner choroid. Now, some people believe it PCV to be a variant of AMD, but once you have the concept of pachychoroid, it is considered to be more of a spectrum of CSC and its complication. And again, because many of these patients have absence of drusen, it indicates that PCV may not be a variant of AMD. While some of the patients of chronic CSC will go on to develop PCV, some eyes will have PNV, that is pachychoroidal neovasculopathy, where you can see occult CNVM, which is there. And on ICG also, you can see occult CNVM hotspot, and you can see the dilated choroidal vessels again in the area of the pathology. You go on to the OCT, again, you can see a type 1 CNVM, with some overlying hyperreflective material. And if you have a look at the choroid, you can see there are only larger choroidal vessels, and most of the other vessels have been replaced with these pachy vessels. This is more or less a normal choroid. Again, it shows that pachychoroid is something which is not present everywhere in the eye. It is just beneath, most appreciable in the area beneath the area of retinal pathology. Now, just to give you a perspective, the first patient with pachychoroid epitheliopathy had typical PCV in the fellow eye. Patient with central serous chorioretinopathy had pigment epitheliopathy in the other eye. Patient with PCV had other eye normal, but the choroid was thicker in the fellow eye. And patient with pachychoroid neovasculopathy had typical CSC with RP gravitational tracts in the fellow eye. So all these point towards the fact that all of these disorders are related and have a common underlying pathophysiology. Now, once we had all these diseases, a new concept of peripapillary pachychoroid syndrome came in, whereby the authors Fujikawa et al. Suggested that these eyes tend to have more pachychoroid features in the peripapillary area. As you can see, this is the OCT scan running from here to here. So in the nasal area, you have changes of pachychoroid, while the temporal choroid is normal. These patients tend to have lesser subretinal fluid and more intraretinal fluid in the papulomacular bundle. Now, the author suggested that these eyes can have optic disc edema and crowded disc syndrome. And in fact, before this entity was described, some of these cases have been described as posterior uveitis or even uveal effusion syndrome in the literature. So when we studied our eyes of peripapillary pachychoroid syndrome, we found that most of these eyes are actually very similar to CSC. And we believe that peripapillary pachychoroid is nothing, but it is a subform of CSC which occurs in the peripapillary area. Now have a look at this particular patient. If you see, this is a young male who has a CNVM complex in the foveal area with some exudation. But have a look at the OCT. You can see there is a CNVM complex, but what is also there is something known as focal choroidal excavation. So this is nothing but there is an excavation in the choroid where the RP is continuous and the retinal layers may or may not follow the RP. So this is what is known as focal choroidal excavation, and it has been shown that most of these FCs occur in the pachychoroid spectrum of disorders. So some authors think that FC is part of the pachychoroid spectrum. But our experience is that these FCs can occur in some of the dystrophies where choroid tends to be thinner. And in fact, we have also described these FCs in the setting of the high myopia where the choroid is extremely thin. So my personal experience is that these FCs are just focal thinnings and can occur in any subset of patients and not necessarily pachychoroid. Now, this is one of my second last cases. If you see, this patient is a young male who came to us with the reduced vision. He was a very high hypermetrop, and patient came to us with metamorphopsia in the left eye. And patient had clinical features of nanophthalmos in the form of macular microfold, as you can see. And in the left eye, patient had subretinal fluid in the left eye. When we did FFA of these patients, we found typical leaks, pinpoint leaks, which were there in the macular area. And if you see periphery of this patient, it suggests that patient have had peripheral effusions where there are pigmentary changes in the periphery. Because there was a focal leak, I just went ahead and lasered this particular spot. And if you can see, the fluid regressed in this particular patient. So we had similar patient, and then we described that serious macular detachment in nanophthalmos is a common finding, and it could also be a manifestation of pachychoroid spectrum, and not all subretinal fluids in the setting of nanophthalmos are uveal effusion syndrome. Another entity which has been described recently is pachydrusen, where you can see these yellow deposits in the macular area. If you see, there's typical pachychoroid features, and you can see these drusen. Now, these drusen tend to be solitary as compared to the AMD drusen, though we do not know their exact significance till now. So what are the implications of pachychoroid syndrome? It can explain to us the underlying pathophysiology of some non-specific pigmentary changes. It also tells us why some CSC patients behave differently, and explains why there are so fewer recurrences after PDT in CSC. It also shows us that PCV may be a distinct entity from AMD, and some idiopathic CNVMs, which we considered earlier as idiopathic, may actually be pachychoroid neovasculopathy. So to conclude, multimodal imaging has helped us in better characterization of pachychoroid spectrum, and CSC now has an extended spectrum. It may have potential impact on therapeutic strategies and visual outcomes in the future. Thank you very much.
Thank you so much, sir, for a phenomenal talk. Very beautifully explained. Sir, one thing I would like to ask, you have, since there is, you said that the definition or the actual thickness beyond which you consider to be pachychoroid is not defined, and your diagnosis of pachychoroid is mostly based upon, seeing the normal eyes and, comparing that, okay, that the larger the vessels, they are dilated. So, sir, to a newcomer, how could they pick up these cases early of a pachychoroid? How would you suggest for those people who have acquired an OCT with the choroidal imaging module?
I think the most important is that the eyes, you know that these are pachychoroid eyes. You have a look at those OCTs, and then you gradually compare them with normal eyes. Over a period of time, the moment you will realize that it is very, very easy to distinguish these eyes. The moment you have a look at the choroid, for example, some of the eyes, if you are, for example, VKH syndrome, the moment they also have a thicker choroid, but there the thickening is diffuse. Okay, and the moment you have a look at these eyes, you will come to know that
this mostly the thickening is in the inner choroid.
It is diffuse thickening. You will not be able to distinguish between the small and the medium and the larger choroidal vessels. But in these patients, The moment you have a look at the choroid, the inner choroid is virtually gone away, and all you can see is larger choroidal vessels. That will give you a clue. I think that is the most important clue to diagnosis of a
I think
pachychoroidal
the
vessel.
same way you showed me a picture of reticular pseudodrusen, and I have been able to pick up patients after that.
Yeah, I guess so. I think we all have our hesitancies before we start making a diagnosis. And I think one thing I always do in my practice is whatever I'm curious about, I tend to diagnose in each and every case. And that gives me, more insight. More times I'm wrong, it gives you more curiosity that I should learn further.
Okay, so sir, one quick question, sir. So you get a case of CSR, one with pachychoroid, one without pachychoroid. How does your approach change in managing them, sir?
Uh, I think the one with pachychoroid is likely to have many more recurrences. So I would be much more keener to go ahead with PDT in such a patient with the rider that we don't have PDT available, the dye available as of now for past 1 year or so. But I would have much lower threshold for doing PDT in such cases.
Okay, sir. Sir, Dr. Mohit, sir, any your comments? Dr. Manish Dupar, Dr. Chekitan, please some comments and questions from a panelist.
My just submission is that postgraduates, especially when they are learning about pachychoroid. So when you're doing a OCT, not all the machines have the enhanced depth imaging. So if your machine has EDI, like in the Zeiss machine, I use the Angioplex 6000. So for that, you have to really take on EDI, then only it gives you EDI. So for postgraduates, when you are comparing scans and all, do remember to take it in the EDI mode. Then that will, you'll be able to get a better scan. That's all.
I think one thing we can do is that people the people who don't have EDI skin is EDI scans or EDI option in their machine is that if they take the eye little closer to the scanning module. So
Sir, I
what
think
happens
that
is
is what, yeah.
it gets inverted. So in that case, you will see the choroid much better.
Initially, that is, I think, sir, Dr. Spade, how he described it by taking the
Exactly.
module closer and getting the image inverted.
Exactly.
Yes, yes.
Sir, in CNV or PCV cases, does the response to anti-VEGF differ in a case with pachychoroid? Does it respond equally well?
I think so. They behave very well. I think there's no difference. The only part is some people believe that Eylea works better in these eyes, but especially in our setup, the patient's affordability is a major issue rather than the other things, whether which particular anti-VEGF is more effective. So, but by and large, most of these anti-VEGFs work equally well in these eyes.
Thank you. Okay, sir. Sir, I think then I'll invite the next speaker, Dr. Pradeep. Is Dr. Pradeep there?
Yes, I am here.
Good evening, sir. So Dr. Pradeep is he is a lieutenant colonel by rank. He is working in the RNR hospital. He's a faculty in Vitretina Services, Department of Ophthalmology, and he too is an alumnus or in retina training from API Center AIMS. Over to you, sir. Most welcome.
So I'll just be sharing my slides. I hope my slides are visible, sir.
Yes, sir.
Good evening, everyone. I'm going to speak about ICG angiography today. So a little bit of the academic talk. The molecule, it emits fluorescence in infrared range, and that is what makes it so peculiar. It is 98% protein bound. So the molecule remains most of the time in the choriocapillaris and does not leak into the choroid like fluorescein. And when we want to see what is underneath the retina, it definitely gives an advantage over any other form of imaging because the choroidal vessels become delineated quite well. And why this technique is unique, because when we are doing FFA, there is a leakage into the choriocapillaris and all you see is a choroidal flush, while the vessels, they are lost in that flush. While an OCT, even if it is a swept source or the EDI OCT, will only tell you about the anatomical evidence of the existence of those vessels, but will not tell you anything about the functionality of those vessels, whether they are leaking, whether they are having a high flow or a low flow. Though OCT-A has given us some insights into these vessels, ICGA still holds a place when it comes to having a definitive diagnosis. Now, things to remember, this is for my colleagues who are going to try ICGA for the first time, that the fluorescence is weaker, go to the higher flash settings. Do not use normal saline to mix the dye. You have to use sterile water. It is a faster bolus compared to the fluorescein dye, and you have to push saline after the dye has been injected to get proper contrast. Iodine allergy has to be remembered, and patient should be specifically asked for. There is no urine discoloration after this procedure. And even if it is extravasated into the arm, it is relatively safe. Now, what changed between the ICG angiography when we were postgraduates and to this date is conversion from flash-based to the confocal SLO-based imaging. Machines like the Zeiss FF450, the Topcon TRC, or the COA, they all use flash-based ICGA. In few of the modalities like uveitis, they may be useful in giving you a diagnosis. But when it comes to picking up the clues about polypoidal choroidal vasculopathy, what you actually require is something which has a CSLO, like the Spectralis HRA, the Nidec, and now even Optos has included it. Now, why should you know about all this? Because since 1999, it has been quite well defined that ICGA picks up CNVs which have already been missed on FFA, almost in 40% in that era. Now imagine the kind of advantage one has when we talk of the new CSLO machines. Now this is how this technology has progressed and revolutionized our thought process. And coming to the stages, the larger vessels will fill earlier. This is how the progression of the ICG goes. And if the RPE is missing, you don't even require an ICGA to look at the choroidal vessels, and very easily you are able to look at the choroid with a standard FFA. These are the terms to be used, hypersenescence and hyposenescence. When we talk in terms of AMD, hotspots and plaque are the terminology we use, while in PCV, it is branching vascular network and polyps, which have been talked about in most of the journals. But I like to bring out a fact here that when you are trying to look for a BVN on an ICG, it's quite difficult. And if somebody talks about a pulsating polyp, I'm yet to see one. It is generally the polyps which are easily captured, and also the technique can be used in CSC. Most of my slides have already been covered by Dr. Vinod, thanks to him. And this is now going to the phases of ICGA, thanks to my dear friend, Dr. Darius. This is the early phase. This is the early mid phase. This is how it looks. And as you see that the phases progress, the choroid does not have the same delineation as earlier. And by the late phase, all vascular details are gone. So you have to know which phase of ICGA you are going to look for your PCV polyps and PCV BVNs. It is the early phase where you pick up these PCV polyps, and it is the early mid phase where you pick up the PCV BVNs. Now, coming to one particular example. Now, talking about classical PCV. Here we can see on the OCT, the double layered fine sort of thumb-like polyp. And now here on the ICG, I'll highlight this a little more. One can see these tiny polyps. And as the phases of the ICGA will go ahead, this BVN and these polyps will keep increasing in their senescence. Now, once again, coming to an example of a classical PCV. Now, why I am giving these examples is that there are images which are circulated between many of our ophthalmologist friends where they need to look for these polyps and BVNs. So this is how they look like, depending on the printout, whether it has been taken in the correct phase. So the ideal thing is to sit on the console and go through the entire phases of the ICG. But that may not be possible for everyone who does not have this machine. So these kind of hypersenescence, which are well defined, if they are corroborating with your OCT pattern, you can safely label the patient as a case of PCV with polyps. Now, one has to go through these phases and the polyps will light up better as the phase progresses. Now, not every CNV and PD is picked up on a CNV, as in this particular example from one can see that this is a beautiful PD. There's a little bit of SRF based on the OCT alone I could have injected. Had I only had the advantage of ICGA, Probably these very mildly hypersenescent polyps would have been missed, which could have been easily picked up on as an occult CNV on the FA and the OCT guidelines. Now, also, we might have a combination of diseases, like in this particular example, we had a case of diabetic retinopathy, which had AMD. The AMD has caused a geographic atrophy in the center, which gives a very funny looking choroidal vascular appearance. But what we have to notice is that in this patient's OCT, since we saw a little bit of fluid, we should go to these polyps, go through them on the OCT, and try to look for evidence of PCV. I think here the polyps are even better delineated. Now, many people have been falsely labeling polyps in BVN, even in cases of standard AMD, where, as enunciated by Dr. Vinod, that unless you have picky choroid, labeling a case as PCV seems a little odd to me. And here in this case, the OCT is absolutely normal. But when you look through this kind of image, this patient was referred to us as a case of PCV asking for further injections. Though we have to ratify these injections being part of the ECHS system, we have to politely decline in such cases. So not everything which hypersinuses on ICGA should be labeled as a polyp and evidence of PCV. And lastly, ICGA also allows you to see through these large bleeds. I'm very sorry I prepared this topic due to change in my topic at the last moment. So I don't have the concurrent ICG to show you. Thank you so much. I'm open to questions.
Thank you, sir, for the talk. I think, sir, questions we can take in the end because we're running a little short of time.
Absolutely.
Next, sir, I would like to invite Dr. Ruchir. Dr. Ruchir is Dr. Ruchir.
Hi, sir. Good evening.
Hi, Ruchir. How are you?
Good, sir. Great.
Dr. Ruchir is also an alumnus of Maulana Azad Medical College and Rajendra Prasad Center for Ophthalmic Sciences. He's done his retina subspecialization under Dr. Rajvardhan Azad and Dr. Atul Kumar. Consequent to that, he has done his ICU fellowship from Germany, and currently he practices in Ghaziabad. Dr. Ruchir, please, over to you.
Yeah, I'll start sharing my screen, sir. Yeah, are my slides visible, sir?
Yes, Ruchir, but yeah.
Yeah, right. Good evening, everyone. Thank you, Sumit, sir, and Karnal Society for giving me this opportunity. So I'll be sharing some of my complex cases of AMD. There's no financial disclosure. The first case is an 83-year-old gentleman. He had a BCV of 6.9 in his left eye. He was a one-eyed patient. Right eye had an old retinal detachment. He first presented to me in September of 2020. The fundus showed a drusenoid PED sort of a structure. So this is the OCT from that time. BCVA 6.9. The subfoveal OCT shows some drusen, but when I go through the other OCT scans, I realize it's more like a drusenoid PED than a case of simple drusens. Still, the patient was maintaining his vision, and there was no emergency to treat the patient for any cause. So the patient was followed up. The patient next came back 6 months later in April 21 with a sudden loss of vision. BCVA at this time was noted to be finger counting close to face. The fundus examination showed a large macular detachment with underlying yellow lesion. The OCT showed me that the patient had developed a retinal pigment epithelial rip. So as you can see, the picture shows a large PED. The temporal side does not have an RPE. There is a lot of intraretinal fluid, a lot of STREM, and a lot of subretinal fluid. I discussed the situation with the patient, and I told him about the loading doses and all the protocols. I gave the first injection ranibizumab to the patient. So patient could not follow up at exactly 4 weeks. There was COVID at that time. He came back on June 4. This is 6 weeks after the initial ranibizumab injection. He did report some initial vision gain, which was lost in the last 2 weeks. So maybe the injection did work for the first 4 weeks, after which there was some recurrence. When I looked at the OCT, it was looking much better, but there was a lot of subretinal fluid persisting. There was less intraretinal fluid, but then again, vision was still finger counting. So I decided to change the treatment regimen at this time. I suggested injection brolucizumab to the patient. And when the patient came back after 2 weeks, his vision had improved to 3/60. There is some further resolution of subretinal fluid. When he came back at 4 weeks after the injection, his BCVA had improved to 660. And as you can see, the subretinal fluid seems to have gone away quite a bit. So this response at 4 weeks seemed to be much better than what ranibizumab had initially shown. Patient came back again at 2 months. This time his vision, to my surprise, was 6/24. And there's no subretinal fluid, whatever at this stage, there's no intraretinal fluid, and the patient was doing pretty well. At 8 weeks, I decided to give the second injection. This is 6 weeks post brolucizumab second injection. BCVA is maintained at 6/24. There's no subretinal fluid. Unfortunately, patient thought that the disease had gone away even after my counseling that he will require further injection. When he came back at 13 weeks, there was a disease recurrence, vision dropped to 660. This is when I had to give the third injection. 3 weeks post brolucizumab 3, vision is again 6/24. Patient is now under follow-up, and the plan is to treat the patient between 8 to 12 weeks whenever he requires the next injection. The second case is a 78-year-old gentleman. He came to me with blurring of vision in the left eye for 2 months. His BCVA was 6/9 in the right eye and 6/12 in the left eye. He was pseudophakic in both his eyes. These are the fundus images. The right eye shows some pigmentary changes. Left eye, the left eye shows some grayish-looking membrane just above the fovea. I did an angiogram which revealed it to be an occult CNV involving the fovea. The right eye, on the other hand, showed just some few window defects. These are the OCT scans from December 2019. The right eye shows more or less normal foveal contour with a single drusen-like structure. Left eye shows some shrimp. The subfoveal area is looking more or less okay. There is some shrimp and there's a low-lying PED sort of a structure. But when I started going through the OCT scans, I realized there was a lot of disease activity. There's a lot of subretinal fluid, a lot of hyperreflective foci, a lot of shrimp, and it was just the subfoveal area which was looking okay. So I gave the patient ranibizumab injection. Patient came back after 5 weeks. BCVA was still 6/12. However, when I looked at the OCTs, there was increase in subretinal fluid in the area superior to the fovea. There's increased hyperreflective foci, and it is only the subfoveal area which is looking more or less similar. And that is why the patient was maintaining his visual acuity. At this stage, I gave the second ranibizumab injection and I asked the patient to follow up after a month. However, this is when COVID hit. Patient did not follow up for a year. He came back in February 21, 1 year after the last injection, with a sudden decrease in vision. This time things had changed drastically. This is the OCT from that time. You can see the height of the PED has increased drastically. There's a lot of shrimp. There's a lot of subretinal fluid. There's a lot of exudations, hyperreflective foci, and the vision has dropped out to finger counting close to face. So looking at the previous partial sort of a response of ranibizumab, I changed the injection to brolucizumab. Patient followed up after a month. His vision had come back to 6/24 from finger counting close to face. These are the comparative images pre and post injection. So as you see, the height of the PED has gone away more or less. The shrimp has also disappeared from the subfoveal area, and there's no subretinal fluid in this scan. However, the benefits do not seem to last more than 3 months. So when the patient came back after 3 months, BCVA had dropped down to 660 and there was a recurrence of the disease. A lot of shrimp, a lot of subretinal fluid, and the PED height also has increased. This is when I gave the second brolucizumab injection at 12 weeks. At 4 weeks, patient's vision had gone up to 6/24. However, if you look at the OCT scans, there's a lot of shrimp still persisting in the subfoveal region. To my surprise, by 6 weeks, the shrimp had also started to go away, and it's only the temporal region that shows a little shrimp that is there. So at 8 weeks, I gave third brolucizumab. This time at 6 weeks, the patient was doing very well. There was just a very low-lying PED. Foveal was looking more or less normal. However, at 10 weeks, again, he had a mild recurrence. There's some subretinal fluid, a little hyperreflective foci. Vision is still 6/24 though. So at 10 weeks, I repeated brolucizumab. This is 4 weeks after brolucizumab, fourth injection. Vision is maintained at 6/24. Again, the plan in this case is similar. Inject every 8 to 12 weeks whenever the patient has a slight recurrence. The third case is a 52-year-old lady. She presented with blurring of vision in the right eye in August 2017. Vision was 6/18 right eye, 6/6 left eye. The fundus showed a dull foveal reflex in the right eye. Both eyes showed few pigmentary changes. OCT showed subretinal fluid with a thickened choroid. This is the OCT from August 2017. So there's a low-lying PED in the right eye with some clear subretinal fluid. Left eye shows, the right eye shows a relatively thickened choroid as well. The left eye also shows thickened choroid and a single tooth, as Dr. Vinod mentioned, a case of probably pachytrusion. So as the patient was, we did an FFA and ICG, no leak could be detected, and OCTA was, an octa was also done, and no membrane could be detected. As the patient did not have any membrane and the fluid seemed to be stable, we did not advise her any anti-VEGF, and we followed her monthly for 3 weeks with no drop in vision. The next follow-up with the patient happened in April 2019. In the meantime, she had already received 3 ranibizumab and 1 aflibercept somewhere else. Partial response was noted, and the funny part was that even with the waxing and waning fluid, her vision seemed stable at 618. So I got some OCT scans from the patient. This is Feb and March 2019. So during this time, patient has already received 3 injections of ranibizumab and 1 aflibercept, and it seems to me that the fluid is increasing between the 2 scans. So this is April 2019. Fluid is a clear subretinal fluid with a low-lying PED in the right eye. Left eye seems okay. I ordered an ICG and an FFA which showed diffuse leakage. However, as the patient had shown no response to previous ranibizumab and aflibercept, and she had no drop in vision, she was not convinced for a repeat aflibercept. So conservative plan of management was followed. Patient came back this time after 14 months, again due to COVID. BCVA was still 618. And when I did the OCT, I realized that the subfoveal fluid had somehow become even less without any treatment, without any injections. So the patient was feeling good. And again, she was asked to come back after some time. She had developed early cataractus changes this time. So the next time when the patient came, this is Feb 2021, her BCVA is 660. As you can see that things have changed drastically. There's a lot of strength, there's a lot of subretinal fluid, and for the first time in 3 years, her vision has decreased below 618. So somehow I had to convince the patient to get an injection. I counseled her to get brolucizumab. She came back 4 weeks after brolucizumab, and her vision has now improved to 6/24. And as you can see, the things have changed drastically. There's no subretinal fluid as of now. Patient then again came back after 10 months. And this is November 2021, BCVA is maintained, and she only has few small subretinal fluid. These are the OCT comparative from August 2019 to November 2021. This is the, I'll just take a few slides. This is the last case. There's a 60-year-old female. She was diagnosed as neovascular AMD. She had already received 3 ranibizumab and 1 aflibercept. Her PCVA was 618 even with all the treatment, and there was no further improvement in vision. This is the fundus picture showing a well-defined membrane complex. The OCT shows subretinal fluid and Schrem. I gave first ranibizumab. There was some response after 2 weeks, although at 4 weeks there was again a disease recurrence. So I counseled the patient to get an injection brolucizumab. Yeah, and for the first time after brolucizumab, her vision improved to 6/9. Now this was a surprise to me and the patient both. However, this was short-lived, as at 6 weeks again she had a recurrence. There was some subretinal fluid. I again gave a brolucizumab. At 2 weeks, vision again comes back to 6/9. At 6 weeks, she again has a mild recurrence. Vision is 6/9 parts. At 7 weeks, I repeat the injection. 6 weeks, vision is again 6/9. At 8 weeks, again a recurrence, 6/9 parts vision and subretinal fluid. So patient has been given 4 brolucizumab now, and she is following up. This is the only patient with brolucizumab where I have to inject between 6 to 8 weeks. So I've given around 35 injections in 23 eyes in most of the indications for CMV, apart from AMD, and I've yet to encounter any intraocular inflammation. I think it gives a better response, and it works in even the worst of cases. Thank you.
Thank you so much, Ruchir. Hats off to your counseling. Our patients hardly listen to us. Sir, before we take up the questions, I'll invite Dr. Amit Gupta. Dr. Amit Gupta is an alumnus of SN Medical College, Agra, and he's done his Vitreoretina Fellowship from Arvind Eye Institute, Coimbatore, and currently he is the head of retina services at Gandhi Eye Hospital, Aligarh. He also has authored a chapter in the book on principles and practice of vitreoretinal surgery. Dr. Amit, please present your talk. Most welcome. Sir, you are not audible, sir. Sir, you are not audible.
Yeah, I'm audible.
Yes, sir. So now
Okay,
you're
thank you.
audible.
Thank you very much.
Good evening, sir.
Good evening. Good evening. Good evening, everyone. Thank you, Colonel of Ophthalmic Society, for giving me this opportunity. And most of the time, we discuss the doctor's perspective or scientific perspective. So it is important for what the patient is thinking about their eyes. So we always discuss the doctor perspective to treat NAMD. We have witnessed the evolution of treatment from observation to lasers, TTT, PDT, and to anti-VEGF. We are also witnessing this era of anti-VEGF from bevacizumab, ranibizumab, aflibercept, brolucizumab, and many more in pipeline. The differences between various anti-VEGF, this slide is very informative. As we can see, the size of this molecule, brolucizumab, is the minimum. This molecular weight is only 26 kilodalton, and the clinical dose is maximum 6 milligram. So I think this also attribute to its higher efficacy and strong performance. So what is patient expectations to us? Patient say that, doctor, you give me a drug which is cheaper in cost. It should be non-invasive, and one dose should cure the disease. So we tell them it's not possible. Then they say, okay, I can pay for expensive drug also if one injection guarantees the cure. So then again, we have to tell them that it's not right now, it is not available. So if it is not a single shot, then tell me the numbers. So this is the most common question I heard from my patients. So please tell me the number. And then they start accumulating the cost of every injection, and they decide whether they are going for first injection or not. So I always tell them, okay, you start with your first injection, and then we see how many injections you will require later. And sometimes we give the evidence on various studies, what has been performed, what is the trend everybody is following. Then they say, okay, doctor, I do not believe in any study or in any drug. I trust you. I come to you and I trust you, and you tell me what is the best you can do for me. So the real challenges for us are under treatment, cost of therapy, frequent flyers. Frequent flyers, I call all those patients, they are diagnosed by someone, injections are given by someone, and follow-up is taken by someone else. So they used to fly from one doctor to another. They have too many questions, and we have limited answers. So what if I or you were a patient? Are we ready to have a monthly or 12 injections of ranibizumab, what Marina and Anchor have shown to us? Or you are ready for 3 monthly loading and then bi-monthly, total 8 injections in your eye for aflibercept. And now brolucizumab is proclaiming 3 loading and then quarterly, total 6 injections. So still, it's like, I think injection number is little more, but the good news is that we are proceeding in the right direction. So definitely we are having a better drug with the evolution, and the number of injections are reduced. So till now, the great sisters like Bivasi, Rani, and Efli have done huge to retina kind and mankind. But now it is the time for Bro to show his muscles. So till now, what I have known about you, Bro, is that you are positive, except few initial hiccups. Yeah, brolucizumab can, you have a potential to reduce the treatment burden. you can help me when others do not perform. And I would say that it is smartly priced and it may take care of under treatment and frequent flyers. So with this background, I want to show some of my cases. So case 1, 59-year-old male, blurring of vision, last 1 month, no comorbidity. This is a picture of left eye, OCD showed active CNVM. And I have given him brolucizumab. This is treatment naive. Most of the patients are treatment naive. So this is an injection after 1 month. There is some reduction in the subretinal fluid, but patient has better vision. Patient was happy, and after second injection, the picture is not here. The patient response, the PD also reduced. Case 2, 61-year-old female, blurring of vision last 2 months. Patient has so many comorbidities also, hypertension, diabetes, and left eye is already scarred. Now, in the right eye, she came with a recent onset blurring of vision. So this is the OCT picture of right eye. And I offered her brolucizumab, and this is a picture after 15 days. So there is marked reduction in SREM and height of SRF also. Interretinal fluid also reduced. And this is a picture, almost complete resolution of SRF and SREM. The patient was very happy. This is case 3, 75-year-old male, blurring of vision last 2 months. So many comorbidities. Actually, I was little worried to give this injection, newer injection to this patient because he was on blood thinners also. But with due consideration and discuss, this is a patient of doctor's father. This patient is doctor's father, and so he discussed and he also searched the literature and he was agreed. So we have given him this injection. This was the pre-injection OCT, and post-injection the vision increased dramatically, and patient was very happy. And this is after 2 months. This is almost complete resolution of PED, SRF, and intraretinal edema. This is 65-year-old female, blurring of vision last 1 month, no comorbidity, and patient came with patient was very furious. Actually, like she was very worried about her vision, and but we counsel her for this treatment naive. No injection was given previously, so we counsel her for brolucizumab, and she was agree for that. And this is the injection after 1 month. This is a condition after 1 month. BCVA increased, patient was happy, clinical picture improved. So this is case 5, 59-year-old male, blurring of vision last 2 months, hypertension, and both eyes pseudoaphakic, and right eye is having CNVM. So this is also treatment naive, and no injection was given previously. So we counsel this patient for brolucizumab, and the result is dramatic. Most of the patients on brolucizumab, they showed very good response with first injection, and I have not given any injection up till 2 months. So there is one patient I have repeated the injection. Rest all the patients, they are not they are doing well with one injection only. So this is 55-year-old male. A patient is, this is the this patient I have given the injection in first this left eye, and now patient came with the right eye with the same problem. The patient was having this problem, but because the vision was less, so he was not ready for injection in this eye. So we treated the better eye, but after the response he got in the right eye, left eye, he was convinced for the left eye injection also, and there is a dramatic improvement in this left eye also. So from 262 he has improved to 560, and there was cataract, so I think the BCVA is little less, but patient happiness was little more. This is again a case. The patient is having very less vision, almost 160 vision, and patient was. We have given the injection, and this is the result after 1 month. So patient has significant improvement in clinical picture and definitely in vision also. So these are my initial experience with brolucizumab. Thank you very much.
Thank you so much, sir. Thank you for your cases and your insight into what actually it is. Our thought process has to be patient-centric and not always, evidence, or what should I say, the publications or the market-centric. I would request some few quick comments from our panelists, Dr. Chekita and Dr. Mohit, please, for your comments and for your questions. And then I'll request comments from our esteemed speakers before we conclude today's session.
Yeah, I have a comment for Dr. Amit. Excellent cases, Dr. Amit. I have a one question for you. Like you have used good experience in treatment naive patients.
Yeah.
So what is the maximum interval you have seen of any recurrence of fluid in first injection? Like how many months you have seen patient without any recurrence of fluid in treatment naive patient after first
All these
injection?
patients have almost 2 months, sir.
Okay.
In one patient, I have given one injection after 2 months only.
That is the maximum you have seen till now.
Yes, sir.
But are you seeing even more than that also in any of the patients? More than 2 months?
Patient, almost 3 months. Some patients are having 3 months. They are coming every 20 days to me. But
so in this, basically, you're not following the this loading doses regime. You're just keeping it rolling. Yeah. And then that's good. I have two cases.
Most of the
same I have
patients are local
experience.
patients, so they come easily for follow-up also. So, so definitely, I call them for a short follow-up, and they are doing well.
Yeah, I have also have the same experience. That is why I think this can be used in treatment naive patient, and they may have even longer, remission for with this one injection also. Good.
Yes, sir. Yes.
Yeah. That is a nice thing. Yeah. And I have one question for Dr. Pradeep sir. It's a very nice talk. I just wanted to know, do you find any difference in the quality of ICG in the Spectralis machine versus the ones which we have like Zeiss or Koa and anything? Or do you think is it because the cost of Spectralis and everything is very high and it is in very few centers? So, what is your take on this?
I'll just say that when we are discussing the machines, Spectralis definitely scores over almost everything else when you are talking about ICG angiography, right? Now, with the NIDEC machine coming up, that is one platform again which has given an extremely good. It gives a very good ICG compared to others. Now, the main path-breaking thing will be inclusion of ICGA by Optos. Now, that is one machine which is not percolated to the system till now. Very soon, few of the government hospitals, we ourselves also will be procuring 8 of them. That is the time we'll come to know that whether the ICGA, how it performs in peripheral diseases. Till now, we were only talking about ICGA in the macular diseases. And the FFA 450, which came from Zeiss, that was the base machine on which all of us have done our post-graduation. But the ICG of that machine does not stand to any consequence when compared to the HRA Spectralis. That is the statement, final statement.
Yeah, do you find a good difference? Right. And so in which selective cases, do you use ICG? Because nowadays, the role of ICG is obviously decreasing, because the treatment per se remains the same, especially in our private scenario. But where do you think really, you will feel that you will definitely go for ICG, especially for therapeutic interventions?
I'll give 2 pointers in this. Like, as I mentioned earlier also, that we have to rectify a lot of injections which come through insurance basis claims. And one ICGA, if it is done in the very early part of the disease, because CNV, the duration of disease for one particular patient will be 5 to 10 years. If one ICGA is done at baseline, and after 4 to 5 years also, if this patient stops having response or starts having a partial response, a second ICGA can compare from the baseline. That is where the actual value of this investigation lies. And the second thing is, When you had a disease, based on your OCT, you started treating the patient because of a rush in OPD, you could not do ICG. Or as you mentioned, that few of our practitioners do not have access to ICG. But at a certain state, you realize that the disease has stopped responding. That is the time where you have to take a call whether what I am seeing is on the OCT is functionally inactive and I need not treat it any longer, and no further treatment response is going to come out of any particular anti-VEGF drug. This is my take on the disease.
Excellent, excellent.
I have one question, Dr. Pradeep.
Yes, sir.
Like, if you, what I feel, I order ICG only in selective cases when I feel that anti-VEGF is not working, and I want to treat the foci, polyps, directly with the laser. If peripheral polyps are there, they are not centered in the foveal zone. So I think, are you doing this thing? Like you are doing frequently ICGs and the disease is little extrafoveal, you are finding the hot spot or polyps. Are you treating with the laser or you are just leaving in the injections only?
Sir,
yeah.
Only for diseases which are more than 3000 micron away. This is what we have adopted. Yeah. Earlier, we were trying to treat diseases which were 1500 micron away.
Only injections?
Focal laser and injection both. Because we graduated from lasers to injections.
Yeah.
Like most of our friends have done otherwise. I started my career with focal lasers for these disease entities. When we used to hunt for that hotspot and then the whole photograph will be taken and our process will laser it. Now,
we used to do a lot of cases of ICG in Arvind, and then the main motive was to laser the disease.
Laser.
Exactly, sir. And I still very firmly believe that if you have a leaking polyp, which is about 3000 micron away from the foveal center, and you find that the exudation which is occurring because of this polyp is now affecting your macula, you should go ahead and laser this, because it is the same principle which applies for a leaking microaneurysm, and it works with polyps as well. Only the burn has to be deeper, and it does leave a lot of scarring in the peripheral area.
Sure, sure.
Okay, so a few quick comments from Dr. Chaitra and Dr. Vinod.
Chaitra, you would like to go first?
Yeah. No, you go, Vinod. I'll do that in the end.
Okay. So I think ICG is very useful, primarily from diagnostic point of view. Therapeutically, two reasons, as Pradeep mentioned. I think one is when your disease is not responding. So primarily you are concerned about PCV. But remember the possibility or probability of finding a polyp on ICG in an eye which has already been treated goes down very quickly. Okay, so if you do in treatment eyes ICG, you will find many more polyps. But if you start doing ICGs once the disease is refractory and has already been treated, there's much less possibility that you will find polyps than actually in the number of eyes they are present. That is number one. Number two, I think certain tumors, it is useful. For example, choroidal hemangiomas, once you trying to find out what is the actual dimension of the tumor. And thirdly, certain white dot syndromes, it may help in understanding the pathophysiology and narrowing down your diagnosis. I think these are 2-3 main points. And last but not the least, I think with OCT nowadays, you get quite a good idea whether it is a polypoidal disease to begin with. So 2-3 things to look for. One is sharp, tall peak PEDs. Second would be if you see a hyporeflective halo beneath a tall peak PED, and it is very important to look at the patient fundus clinically. If you have younger patient, absence of brucin, a lot of exudation at the posterior pole. These are all pointers toward possible PCV. And I think 80-90% of the cases we can diagnose without ICG. And of course, if you have access to ICG, it's apart from a financial aspect, there's no harm in getting it done.
I'll just add quickly what Vinod said regarding diagnostics. I would like to add therapeutics. I think therapeutics, especially when we were using PDT, we could not do without it. And if in case it does come back, it's very, very important that we have ICG. And luckily, we have it at our institute and we know its value. Second is, even when you want to do focal lasers, it's pretty helpful. So then again, that is one indication. And the third thing, as Vinod said, I think a very important thing is when you want to reclassify the disease, maybe you're thinking in some lines and the patient is not responding, you want to either change the pharmacotherapy or you want to do like a focal laser to reclassify or to re-diagnose the lesions itself. So many times the angiography has helped quite a lot. And adding to the the angiography is also the advantage of Opta now. I think that is something that we have to explore more and more as it becomes more and more a popular tool.
Right, ma'am.
I would just like to say one or two words, Sumit.
Yes.
It's just that, for the young generation who's coming in, I would really want that they should use multimodal imaging. You just don't go on OCT or just don't go on one thing, So I think you should do OCT angiography if you have access to it. If you don't have access to that, then a simple fluorescein, that also gives you a lot of information when it is a treatment naive thing. And probably whichever drug you use, there should be a loading dose, and that is how you should proceed. That is what I personally feel. That's how we have been taught and how we have been functioning and seeing things work. So, and probably ranibizumab and even Eylea, and then to non-responders brolucizumab as well. So that has been our personal experience till now. So that's all. Thank you.
And I think I'll add bevacizumab to that. We shouldn't be forgetting that.
Absolutely.
Avastin is very, very important. And believe me, 90% of our patients get Avastin and they all behave very well, provided we are following a strict protocol for injecting them. And we have all seen whichever molecule you inject, if the treatment protocol is not good, ultimately you are going to lose the vision. So Avastin should not be forgotten at all. It is very, very important.
Very true, sir.
Absolutely.
Right, sir. I think, are there any more comments before we conclude, sir? Right.
Do you think that the concept of loading dose might change with brolucizumab in the coming few days, provided the effect is lasting longer? A lot of people have now stopped using brolucizumab on a monthly basis.
Yes. So Dr. Vinod, Chetra ma'am, Dr. Ruchir.
What was the question again? Sorry.
Do you think we still need monthly loading doses in brolucizumab, or do you think we
Yes,
can?
Yes, absolutely. As of now, still for AMD, I would prefer to give loading doses. Let's see, with future evidence, because as of now, like I was showing you in one of the cases, every 8 weeks, the patient is coming back with the fluid. So we may probably be able to titrate it, but I don't think the real world evidence or the literature tells that we don't have to do loading doses. As per recommendation, loading doses for AMD still goes.
Yes.
Apurva,
thank you.
Yeah, hi. I would want to make a comment. Dr. Chetra, ma'am, I think I've spoken about this previously also. The thing is that when we had anti-VEGF, when we have bevacizumab and ranibizumab, we know the efficacy lasts for 4 weeks. So we shifted from monthly injections, loading dose from monthly injections to PRN to treat and extend. Then came aflibercept. And there we talk about now treat and extend and not about PRN with the loading dose. And now we have brolucizumab, and apparently the effectivity is more. So I think what Apoor said and what I also feel is that like your patient also, recurrence happens at 8 weeks. I have only one single patient where recurrence happens at 6 weeks. Apart from that, all patients never required more frequent injections. So probably we can try to titrate and get a better regimen for the newer injections at least. I mean, we are waiting for data to come. Maybe we can generate data to get to a better regimen. Maybe we are injecting more. For like Merlin study, when the inflammations happened, they happened in monthly injections of brolucizumab. So that was one concern why I never gave monthly injections. I was very scared.
But Ruchir, I think as far as treatment naive patients goes, we cannot really take the risk unless we know how the recurrence pattern is. I can understand if you're doing it for other treated, pre-treated eyes. But when we are going ahead with treatment-naive eyes, I think most of the drug protocols have given us loading dose. The stability is supposed to be better. Also, the drying effect lasts longer. Long-term visual outcomes are better when you treat the disease more aggressively to start off with. So that was my thinking as far as going with the loading dose goes. When I'm going for second drug or as a rescue therapy for some other pre-treated eye, then I agree that it's not required to go for loading.
Right.
I think this market is very, very hot, and in very shortly we'll have port delivery systems, and
Yes,
where they will be working for longer periods of time with a safer drug. So this particular market is going to be very, very competitive. Let's see where we are headed.
Do you think PDS is also going to be a requirement for AMD? I thought that would help us more with respect to DME. Because I think with AMD, at least after 2 or 3 injections, at least for a little period of time, we do get some stability. I think we can then have probably lower, acting drugs for the PDS for AMD patients, I think.
Yeah, it's kind of monthly dosage. I think I don't see that day is far when we'll be using port delivery for everything. Once the patient gets a disease, put that in for 6 months.
PDS will require a surgical implantation. No? So
Yes.
I think initial studies have also reported some complications with respect to the surgical implantations like vitreous hemorrhage, RD, end of. I think there have been some reports. So I think maybe it may not completely replace.
That is an evolution phase, and we may have some better thing, surely.
So yes, we go back to bevacizumab.
Thank you, sir. I think now we can all break for dinner.
Yeah,
thank you.
Where's dinner? Where is dinner?
Virtual dinner.
Virtual dinner.
Virtual dinner, yeah. That is
we will all meet for a real dinner soon.
And Dr. Sumit will eat on behalf of us. He will tell us the flavors.
So I request everyone to switch on their cameras. I think the Novartis people want a clinical photograph of ours that can be used for their official. So,
okay, so I'm driving, so.
Thank you, sir. Thank you so much, sir. Thank you, everyone. On behalf of Karnal Ophthalmic Society, I and Dr. Adviti are indebted to you for joining for this event and providing us with your knowledge and expertise. Thank you, everyone.
Thank you, sir.
Thanks a
lot.
lot.
Thank you.
Thank you, Doctor.
Thank you. Thank you. Bye.
Everybody.
Good evening.
Bye.
Good night, sir.
A very good night to all of you.
Good night, everybody.